Dr. Leeper is an instructor of medicine and member of the Stanford Vascular Medicine Biology program. He holds degrees with honors in chemistry and medicine from the University of Chicago and completed his internal medicine training at the University of California, San Francisco. Dr. Leeper joined the clinical investigator pathway at Stanford University in 2005 and served as the division's chief cardiovascular fellow in 2007. Today, he'll talk mainly around cardiovascular disease, tips for prevention, and the future of cardiovascular technology. So with that, I'll hand it to Dr. Leeper.
Well, thanks, Mina, and I wanted to thank the American Heart Association and Google for having me come talk today. And as she said, we'll try to have a little fun today talking about cardiovascular medicine, past, present, and future. And so I thought we would just start with a little bit of background about the disease itself. Why should we care about cardiovascular health? And then have some fun going over the major historic advances over the short window from 200 BC to today. And then we'll spend a fair bit of time talking about how you can manage your own cardiovascular risk and ways to think about improving your own longevity. And wrap it up with the future of cardiovascular medicine, where I think that we're heading, how we're going to leverage advances in genetics and technology to uncover the hidden risk that we still can't address. And this is going to be an informal talk. Hopefully nothing is too technical. And please, it's a small enough group. If you have questions, just shout them out. I'd be happy to field questions as best I can as we go along. So a little background, why should you care about cardiovascular disease? Well, it's the leading killer in the world, and since 1990, more people have died from heart disease than any other known illness. It claims nearly 1 million American lives per year, and when you look at some of the other leading causes of death, it's obvious how important cardiovascular disease is, in that it accounts for more deaths than cancer, HIV and AIDS, and accidents combined. And the National Institute of Health estimates that heart disease costs upwards of $500 billion per year, and that's just the direct cost, things like hospitalizations and surgery and the medications we would take, and it doesn't even begin to capture the indirect costs, so time lost from work, decreased productivity, time lost due to early death. And so all in all, it's an incredibly important problem. But it's also an area where we've made a lot of progress, and the data on the right is a study from Scotland showing all 5 million residents of the country from 1975 to 1994. And basically, we've made major advances, and the risk of dying from cardiovascular disease has fallen by about a quarter over that time period. And this is due to both earlier diagnosis, but also more aggressive treatment. And you can see that we've made advances in pretty much every aspect of cardiovascular medicine, whether we're talking about heart failure, heart attacks, smoking cessation, etc. And so really we've come quite a long way in just one generation. But we still have quite a lot of work to do, and sadly these curves have really plateaued over the last decade or so. And in fact, we're getting worse in some areas. So people are surviving what would have been the widowmaker heart attack, but now they're going on to survive with congestive heart failure. And heart failure admissions are actually increasing in the United States, and it's now the most common discharge diagnosis for all hospitalizations, according to Medicare. And there continue to be a number of socioeconomic disparities, so men still have far more heart disease than women, blacks have far more than whites. And perhaps most depressingly, there are some estimates that heart disease has now overtaken even infectious diseases as the leading cause of death worldwide. So now Philip Morris and McDonald's are killing more people than tuberculosis and cholera, and so that's a fairly depressing fact. So where are we today? I thought we could try to appreciate the past to understand where we got to in 2011. And so we'll go back just a few years to 200 BC with the first cardiovascular therapy. This is the medical leech, and at that time, this was used to treat an imbalance in the 4 humors, which were blood, phlegm, black bile, and yellow bile. And this was given to people who were sanguine or were red from their inflammation or their congestive heart failure, for example. And this really isn't just a historical artifact. We still use leeches today to help with wound healing and microsurgery, and it turns out the leech is able to stay attached because of a small amount of an endogenous anticoagulant in its saliva. And we now use a medicine called Hirudo from the Hirudo medicinalis every day in our cath labs as a way to prevent blood clotting in people that are having heart attacks. So this was our first cardiovascular drug, essentially. We then have to fast forward 1,800 years to the first great anatomic description, where we had William Harvey's De Motu Cordis in 1628. This was an amazing tour de force where, without the benefit of the microscope, which hadn't been invented by Leeuwenhoek, he was able to describe arteries and the veins, and even though he couldn't see them, he postulated the presence of capillaries connecting them. And he, for the first time, was able to say that we do not produce 540 pounds of blood per day, which people previously thought the liver was responsible for, but actually that it circulates throughout the body round and round. And this was a major triumph, but he really couldn't pin down the intricacies of the heart itself, and he was quoted as saying that it was only for God to understand the heart, but at least we knew about the circulation. Within 100 years, the heart had been fully described by the anatomist de Vicenne from France. We now knew there were 4 chambers, 4 valves, 2 atria, 2 ventricles. And he went on to even describe the first cardiovascular condition, which was mitral stenosis, shown on the right, where there was narrowing of a heart valve from rheumatic fever. And so now we really understood how the heart and blood vessels were interconnected and had our first pathological diagnosis. Within 30 years, blood pressure was measured. Shown here, Stephen Hales is inserting a glass tube into the carotid artery of a sedated horse. And within the next 100 years, physical examination became a priority. And in 1816, René Laennec invented the stethoscope. And up to that point, the physician would press his or her ear to the chest of what was often a frail old man. And Laennec had been presented with a young woman, and he was too embarrassed to ask her to disrobe and press his ear to her chest. And so he had been observing children holding tubes to their ears and scratching to transmit noise. And thus we had the first physical examination tool. And to this day, Laennec is responsible for many of the physical exam findings that we use in our daily practice. By 1903, the EKG was invented. I think this is one of the more hilarious pictures I've ever seen. It was known that the beating of the heart was accompanied by electrical activity, but it was too faint to be measured. And so Willem Einthoven in 1903 used a string galvanometer powered by 2 powerful electromagnets to operate this 600-pound machine. And I just think he's going to get electrocuted at any moment. But now we have the electrocardiogram and the beginning of the field of electrophysiology. Within 10 years, James Herrick was using this EKG to diagnose acute heart attacks. So it became clear that the electrical activity was deranged in people having an acute heart attack, and he called for the use in people with chest pain. And to this day, if you go to the emergency room, the first thing they'll do is they'll check your EKG. But Herrick went further. He was the first person to describe atherosclerosis as the buildup of cholesterol and fat in the coronary arteries. He described the blood clotting that occurs during heart attacks, and that laid the groundwork for many of the therapeutics we use commonly today, 100 years later. Now, it gets even more fun, and people became really focused on delivering drugs into the heart itself. And there was one young surgical resident who had just graduated from medical school that was obsessed with catheterizing the heart. And his professors and mentors told him that this was not compatible with life, and he was forbidden from doing this. So late at night, he actually anesthetized his own arm and snaked this plastic tube up through the vein, over his arm, and into his heart. And so he walked downstairs to the basement of his hospital where the X-ray machine was, and you can see the first X-ray of the human heart catheterization with the plastic tube coming up and over and going down into the heart. So he showed his boss the results the next day. He was fired on the spot for self-experimentation. He was actually ostracized from the field. He never practiced in cardiology again, but luckily 30 years later he received the Nobel Prize in Medicine for this pioneering work, and we use this every day. So, but this really allowed us to do more and more invasive procedures. And in 1952, we had the first open heart surgery. And this was before we had the cardiopulmonary bypass machine. But John Lewis was taking care of a 5-year-old girl with an ASD, which is basically a hole in the heart, and he knew that she couldn't survive. And so without being able to put her on bypass, he induced deep hypothermia and made her quite cold so she wouldn't suffer from the lack of oxygen and blood flow to the brain. He basically plugged off the venous return to the blood so no blood was going through the body, and rapidly opened her heart, sewed the hole closed, and she went on to lead a normal life. So this was the first successful open heart surgery. Quickly followed by the first mechanical valve. This is Charles Hufnagel, who had been working on plastics as a way to replace blood vessels, and he developed this ball cage device, which would basically have a plastic tube with a plastic ball inside, and he put this into the heart of a woman dying of aortic stenosis, or narrowing of the heart valve, which keeps blood from going out to the body. And when the heart would contract, it would push this ball forward and allow blood to be ejected into the body, and as the heart relaxed, the ball fell back down and blocked the opening so blood couldn't come backwards into the heart. And so here we have the first mechanical heart valve. Of course, we do many of these every day. And later that year, the heart-lung machine was invented, allowing even more and more aggressive open heart surgeries. Later that decade, even cooler device was invented, the portable pacemaker. And I think this story is fun about Earl Bakken, who was a self-described nerd. So he had been picked on as a child, and he invented electroshock device so he could fend off the bullies when he was getting beat up growing up. And he went on and studied electrical engineering and started this small company called Medtronic out of the garage near his house in Minnesota. And he developed a friendship with one of the surgeons at the University of Minnesota. And that time, this surgeon was operating on a baby who required external pacemaking to keep his heart going. But at that time, the pacemakers were the size of a refrigerator and were plugged into the wall. And that night, the power went out in the hospital. His patient died. And so the next day, he went to talk to Bakken about finding a way to miniaturize this technology. And it just so happens that Bakken had been reading a copy of Popular Mechanics that had a description of the circuitry of the metronome. And so using this as a framework, he invented the first transistorized pacemaker shown on the bottom left. And later that week, it was being used in children to keep them alive throughout their open heart surgery. So pretty amazing. And I don't think he got picked on too much later in life. As you know, Medtronic has gone on to become the world's leading pacemaker and defibrillator company. So I think he did okay at the end of it all. In the next decade, mechanical assist devices were invented, and these were mechanical pumps used to support a failing heart. And this is a picture on the left of Mike DeBakey, who's one of the most famous cardiac surgeons of all time, with an early device. And on the right-hand side, you can see the type of impeller-based design that we use today, which is no longer a pump. It actually has a rotational impeller that drives blood through the same way that a submarine engine is used to propel a submarine through the water. And he was responsible for a number of amazing advances, but now we could keep people alive who had failing hearts, at least with these mechanical devices. But the next great innovation was cardiac transplantation, and this is Norm Shumway on the left, who is the great father of transplant surgery. He worked at Stanford. I had the distinct pleasure of getting to know him before his death a few years ago. And Shumway was not only an amazing surgeon, but he also really fought hard to understand immunosuppression and how to develop therapies that would keep the body from rejecting the transplanted heart. And you can see he did a number of surgeries on his hero dogs. Here was Sam, one of the first dogs to receive a heart transplant. And the politics got interesting. One of his trainees, Christian Barnard, actually left to go back to South Africa and did kind of an 11th hour first human transplant in his home country. That patient didn't do too well. He only lived for 2 weeks. And there actually was a lot of pushback in the lay press, but Shumway persisted, and as you all know, there have been over 60,000 heart transplants performed worldwide now, and largely due to efforts of this amazing pioneer. And just another word on transplantation at Stanford. This remains one of our major focuses. We, of course, performed the first heart transplantation in the United States, the first heart-lung transplantation in the world. And this is a picture of one of my early patients at Stanford. This is just a neat story about a bloke named Joe Matthews who came over from England to study college and play high-level rugby. And he came in to see me when he found that he couldn't continue to outrun his teammates wearing flip-flops, something that he could always do beforehand. And it turns out that compared to the normal heart on top, which is, you can see, contracting with the valves opening and closing, his heart looked like this. And you can see that the heart is barely moving. The ejection fraction is probably less than 10% of the blood volume in the heart is being pumped out with each cycle. And his heart had been attacked by a virus. And I'll never forget, we basically had to tie this kid to the bed. You know, he wanted to keep going up and down the stairs to maintain his fitness. And we started putting on the new medicines, trying to help strengthen his heart, and it wasn't getting any better. And we went to put a defibrillator in him, and he actually died on the table. And through the heroic efforts of our head of surgery, Bobby Robbins, they opened his chest on the table. They put in one of these mechanical hearts, and actually 2 weeks later, he got a heart transplantation. And now Joe just sent me these pictures from last week. This is his first full contact rugby game 4 years later. And he's now completed college, started skydiving. He's run 2 marathons, and he competes in the Transplant Olympics. And you can read more about him at englishjoe.net. He's a really fun kid. And he did give me permission to show his pictures here. So this remains one of our major expertises at Stanford. And things got less and less invasive after that. Andreas Gruentzig performed the first angioplasty in 1977. He used kitchen appliances. So he took apart his toaster and his blender, I think it was, and created this balloon, basically, which he used to open up the artery of a patient with angina. And sure enough, I mean, these are fuzzy pictures compared to today's standards, but the blood flow was restored. He had no more chest pain, and within 10 years, he had not had any signs of heart attack. So this laid the groundwork for balloon angioplasty and stenting, which are some of the most common procedures we do today. The first fully mechanical heart was implanted in 1982. Another fun story about a dentist named Barney Clark. He lived for 112 days without the benefit of a human heart. It didn't go swimmingly well for him. He bled several times. He was confused quite often. He actually asked to die at one point. But these devices have been improved on quite a lot. They're getting miniaturized and at the very least are being used now as a way to bridge people to transplantation and with the hopes that one day we can fully replace the human heart. And the hits have kept on coming. Yes?
So do these completely mechanical hearts are continuous pump devices or people still have walls and stuff like that?
That's a great question. So we used to think that you had to have a heartbeat. You know, you had to have a systolic and diastolic blood pressure. But it turns out that now we use these Impella devices, which have no blood pressure. So if you try to feel the pulse of a patient who has one of these in, you can't feel anything. And we thought that, oh no, the kidneys need to have that pressure head coming and going. But it turns out they don't. So actually more of the, recent designs use these which don't have ball bearings. They have fewer parts that can break down and fewer places for blood clots to form. The stroke is a major complication of these things. You can imagine with all the back and forth pumping. Okay. Yeah, and then I was just going to wrap up the history by saying that things have gotten even more and more exciting. You know, in the last 2 or 3 decades, the number of pharmaceutical discoveries have been incredible, giving us statins and blood thinners and hypertension drugs. And even now, we don't use the balloon. We use metal stents to open the arteries, and they even can elute drugs. So 2 of the most common drugs we coat these stents with are paclitaxel and sirolimus. And the one on the left, paclitaxel, was discovered in the bark of the Pacific yew tree, which only grows in the northwestern United States. And the other is found in the cell wall of a bacteria which grows in the soil of Rapa Nui in Easter Island. So you can just see that it's an incredible history with a number of people making very astute, serendipitous observations, which have led to rather remarkable advances. But like I said, we've made a lot of progress, but we're still not perfect. And we've come a long way since 1891 when this famous painting was first created. And we're not quite in this era where you see the caring physician gazing intently on his sick patient. This is before the era of antibiotics. But we still have quite a ways to go. And as the American Heart asked me to talk about, we can talk now about where we are today and what you can do to protect yourself. And so it turns out that there is some good news, and we can now identify several risk factors which drive disease. And in this large study across 52 countries, there are basically 9 risk factors which all told can account for as much as 90% of your chance for having a heart attack. And many of them are the ones you would kind of guess, like being a smoker, being a diabetic, having a sedentary lifestyle. But I think this is positive because not only are these identifiable, but many of them are reversible. And it turns out that clean living actually does help. In the Nurses' Health Study, which looked at over 80,000 nurses, I believe, who they followed prospectively for 20 years, if you are able to remain thin and eat well and exercise regularly and not smoke, these nurses could reduce their risk by up to 85%. But the other hand is that only 5% of this relatively conscientious, health-focused group was able to maintain all of these lifestyle changes for the full 20 years. So the question is, what can you do today? And we'll start with diet and exercise. And of course, we all love our funny fat men, and I miss Chris Farley quite a lot. But I want to start by showing you some depressing slides. This is data from the CDC, and it shows the obesity map in America in 1985. And so in light blue, less than 10% of the state was obese, and that meant 30 pounds or more overweight, give or take. And the kind of periwinkle blue was 10 to 15% of the state is overweight. Okay? Here's 1986. Here's 1987. Here's 1988. Here's 1989. Here's 1990. Here's 1991. America's gotten so fat, we had to create a new category where 15 to 20% of the patients are overweight. 1992, 1993, 1994, 1995, 1996, 1997, another category. Now over 20% of the people in the state are overweight. 1998, Alaska joins the fray. 1999, 2000, 2001, now over a quarter of the population is obese. 2002, 2003, 2004, 2005, another category, over 30% of the entire state population is obese. That's every third person. 2006, 2007, 2008, and the last year we have data for is 2009. So it's pretty depressing data. And I really do worry about this. This is a hilarious cartoon, but you have to wonder if a lot of the benefit that we've been able to achieve is going to be undone by the obesity epidemic, which is a very real phenomenon. So what can you do? Well, it turns out that exercising does reduce your cardiovascular risk. And the lower right-hand study is, I believe, yes, sir.
It would be good if you repeat questions because anybody watching on the video.
Sure.
Since I'm not speaking to the microphone. So in that whole trend, at the same time, you could argue people are trying to exercise better, people are trying to eat better. There's been a huge push for low-fat diets.
Yeah.
Yet you have this trend of obesity. So in the face of all these actions that culturally seem to be happening, why is this happening?
Yes, the question is, why is this happening if we're becoming more and more health conscious? And I'll talk about that on the next slide, if that's okay, about the dietary changes that have been going on. And I agree that we are more aware of it, but I think that we're being sabotaged by the advent of very cheap, large portion processed foods, whether you eat out or even just get things at home. And I think high fructose corn syrup is probably the key element. We now know that 20% of our daily caloric intake nationwide is from high fructose corn syrup, and I think that's just a thing that we didn't have a generation ago. But it's a great question. So before we get to diet, we'll talk about exercise. And the take home here is that exercising can reduce your risk. And the blue slides show that even if you do occasional or light exercise, you can reduce your risk by about 12%. And you may say, well, if you exercise more, you're probably also less likely to smoke, and so how do you know that you're controlling for all of these things? The upper study is from Finland, where they looked at twins, where one twin was sedentary and the other performed exercise. And as you can see, that if a twin even did occasional or conditioning level exercise, they had a marked reduction in their cardiovascular risk. And so that takes away all the confounders of genetics or other things, and this is pretty robust evidence that exercising will help. And so taken together, the Department of Health and Human Services recommends 150 minutes per week of exercise. And that doesn't have to be training for the next marathon. It can just be gardening, dancing, whatever it is you can do to get your heart rate up. Yes, sir. No, it's a good question. And, we don't really know. Is there too much? Can you overdo it? I'll show you some examples of other athletes in a minute. But yeah, it's an astute observation that maybe you can do too much. But as of now, I don't ever tell people to not go, particularly a young group such as this. I think that for elderly patients who might already have heart disease, we do have to be more conscientious about not overdoing it and putting yourself at risk. That's a great question. And so here, this slide talks about the diet. And I think one of the points that's worth making is looking at just the serving size compared to the 1960s and today. The average bagel has gotten twice as big. The average cheeseburger, the average French fries, the size of our soda, our big gulps. It's all gotten way out of control. And while we could spend the whole hour talking about the merits of the Mediterranean diet or the Atkins diet or whatever, I really do think it's mainly about common sense and portion control. And I really tell my patients, don't try to go nuts. Using a sensible approach. If you can go hungry by 100 calories a day, so that means skip that Nutri-Grain bar in the morning or maybe don't have that yogurt in the morning, that will give you half a pound a week. And half a pound a week is 25 pounds a year. And that's enough to get you down into the lower risk group based on the obesity trends that we saw earlier. So I think a sensible, healthy diet is a useful approach. What about smoking? In California, we think that smoking is a thing of the past, but it's really not. I mean, basically a quarter of American males are still smoking, and over half of males worldwide are smoking in developing countries. And we know that smoking worsens basically every aspect of cardiovascular disease. It makes your cholesterol higher, makes your blood pressure higher, makes your vessels more inflamed, and it raises your risk of heart attack sixfold, and the risk goes up with the more cigarettes you smoke. But on the other hand, quitting smoking is incredibly helpful, and no matter how old you are, what sex you are, where you're from, how long you've been smoking, how many cigarettes you smoke a day, if you're able to quit, you can derive a dramatic benefit, as much as 47% in some studies. And the good news is that the benefit begins to accrue as quickly as 2 years after you quit. And if you look out to the right, if you're able to quit smoking for a full decade, your risk of heart disease goes back down to the same level as patients that have never ever smoked. So I really do tell my patients it's never too late. You can get benefit very quickly, and if you can really kick the habit, you'll derive remarkable benefit. And now I couldn't help but notice there were some smokers outside on the way in today, so I know that even at Google there do seem to be a few smokers. And so in contrast to when I was trained and people said, oh, it's mind over matter, you just got to quit and get serious, we now know that there are clearly neurochemical changes in the brain and there are genetic predispositions which make you more likely to smoke. So don't go it alone. I would say if you do smoke or you know somebody that does, have them work with their doctor to get counseling and also to try pharmacotherapy, which can alter the neurotransmitters in the brain to reduce this very real phenomenon of habitual craving. Okay, hypertension, high blood pressure. This is probably the most important thing that you can do as a group because you are probably the group that's most at risk of having a borderline blood pressure and seeing your internist and them saying, we'll check it next year and blowing it off. You really cannot accept this when you are taking your own health into account. First off, it's an incredibly important problem. A third of Americans are now hypertensive. It probably has a lot to do with our diet and the increase in salt intake from the processed foods. But it's also an incredibly silent killer. So Remember, people that are hypertensive often don't feel it. So they'll go through their whole lives, and then one day they'll have some huge clinical event, and that can be the end of it all. Over 2/3 of people having their first heart attack are hypertensive. 80% of people having their first stroke are hypertensive. And 3/4 of people who have congestive heart failure have a history of high blood pressure. So remember, you can go all the way through your life accruing this risk, and then at the end you'll have a sudden event. And just to highlight this is a picture of FDR, our 32nd president, and I wanted to tell a lot of fun facts. My wife wouldn't let me tell all my fun facts. But anyway, in addition to having polio, FDR had blood pressures in the 215/110 range. And remember, normal is like 130/80. And this is with access to the U.S. Surgeon General and the best care in the world. But they didn't want to treat his blood pressure. They were worried that he would have side effects. He was not having any sequelae from his high blood pressure. And here he is at the end of World War II. He's sitting for a portrait. The portrait's half done, and he fell over from a massive hemorrhagic stroke and died. And that left us with the so-called unfinished portrait. And so this is just to highlight the point that you can't ignore this. Every time your blood pressure goes up by 20 points, your risk doubles. But if you can lower it even marginally, 5 or 6 points, you can have a 20% reduction in your risk of heart disease. Yes, ma'am.
I have a consistent low blood pressure, 90/60. Should I feel lucky or should I be worse?
Oh, you're so lucky. I wish I had your blood pressure. The question is can you go too low? I think not. 90/60 for a young woman, that's fantastic. You do not need to worry. There are some intricacies about blood pressure as we age, as the blood vessel becomes more stiff, and you'll see a widening gap between the systolic and diastolic. And that has some ramifications about the amplitude of the reflected wave, so I won't get into all of those intricacies. But for a young woman, good for you. That's great. So you do not need to worry. You can have as much salt as you like. The rest of us, maybe not so much. Okay, dyslipidemia, high cholesterol. Everybody knows cholesterol is bad for you. Whether you have heart disease or you don't, higher levels of cholesterol lead to worse outcomes. And again, just to highlight that our cholesterol levels, things that we consider normal, are totally artificial and a result of the Western diet. I mean, my baby's in the back of the room. Babies are born with LDL cholesterols of 70. And so, think about the last time you had your cholesterol measured. Was it near 70? So this is really a reflection of our diet and sedentary lifestyle. And you can get a significant benefit by exercising, and you can improve your lipid profile with red wine intake, for example. But if you do have high cholesterol and you have risk factors, you're probably going to need to be put on a statin one day. And statins are drugs like Lipitor, Crestor, etc. They also have a fun story. They were discovered by Japanese scientists in this mold, Penicillium citrinum, which grows on orange peels. And this astute observation led to the first statin being developed by Merck. But suffice it to say that there have been now dozens or maybe even hundreds of trials showing that statins will provide marked survival benefits for people that have heart disease. And even this study here is looking at 17,000 healthy men that are 50 or over, and you're seeing that being put on Crestor can reduce your relative risk of heart disease by maybe 50% for people that don't have documented disease. And yes, sir.
What are common side effects of being on statins?
So side effects of statins, well, on the whole, they're fairly well tolerated on a population level. People can get what's known as myositis, which is basically inflammation and injury of the muscles. So people will sometimes say, my large muscles ache. And in some rare cases, that can be serious and life-threatening. And an even rarer side effect is that it can affect the liver. But we, tend to start these drugs with relative impunity, and we do screen for these things down the road. But on the whole, 99.5% of my patients take a statin with really no untoward effect. So pretty well tolerated. I will say that this study, the Jupiter trial, was picked up on by the lay press, and the first thing is, should this really be put in the water, and what are the health economic considerations there? And even Stephen Colbert, I didn't want to. I tried to get the link up, but here he is debating at one of the Stanford cardiology faculty that I work with about whether or not Crestor should be given to all healthy men. And needless to say, Stephen Colbert pretty handily defeated my coworker. But basically, I think that if you do have a lot of risk factors, you have a strong family history, you have high blood pressure, and your cholesterol is high, most likely you'll need to get it down, and statins are the most effective way to do that. Yes, sir.
What about the view that through extreme lifestyle changes, diet, exercise, you can actually reverse high cholesterol without a statin? I think there are like Dr. Roizen or Ornish, some of these guys that aren't necessarily against that, but really don't buy into it. This is the solve all for.
Yeah. So the question is, can you adjust these parameters with extreme lifestyle modifications? And, maybe I'm just kind of a young, jaded guy, and I just think, that doesn't work. I think, let me rephrase. I think that there are clear studies showing that you can lower your blood pressure by going on the DASH diet, but you get about 2 millimeters of mercury. Okay. If you are a heavy drinker and you quit drinking, that can lower your blood pressure by about 4 millimeters of mercury. Cholesterol, if you do get really serious about your diet and you do exercise, you can, in some cases, reduce your cholesterol by maybe 20 points. And whether I'm jaded or I just, haven't seen enough motivated patients, I haven't yet seen a single patient in my clinic that was able to get his blood pressure from 160 down to 130 just by giving up McDonald's French fries. And maybe there are people out there, and to be sure, the guidelines still suggest that you should start with lifestyle modification. And it's probably fair to give it the old college try for 6 months and then recheck it. But what I'm imploring you to do is, if you give it the college try and 6 months go by and you're still, in the risk range, then you need to get serious and get on top of it with pharmacotherapy. That's just an opinion. Sir.
As an example, my goods was low as 31, and within about a year, I got to 49. It took 3.5 years.
Okay. Well,
No statins.
that's great. Well, good for you, and and that's great. And I hope you're drinking some red wine to help do that as well. You can get these marginal increases, and congratulations to you. I'll use you as my first example of a person that was able to do it. I haven't been practicing that long, but in my 7 or 8 years, I haven't seen a patient yet. So that's great news. Oh yeah. Oh wow, fantastic, sir. Yeah, I'll talk about the questions about wine, and I will talk about wine in just a moment. So it's my favorite topic. Okay. All right. Oh yeah. Yeah. It turns out there are probably dozens of different fractions of cholesterol, but we mainly focus on LDL being the bad cholesterol and HDL being the good cholesterol. So the question is, what are the differences? And without getting into too much detail, the HDL is kind of like it's like a vacuum. It sucks the bad atherosclerosis out of the blood vessel wall, and LDL does the opposite. It carries very inflammatory cholesterol products and deposits them there, and that's how the plaque gets built up. So as a general rule, you want your LDL to be as low as possible and your HDL to be as high as possible. And LDL can be very effectively lowered with statins. HDL is a bit harder to raise. You can use niacin, which is an older drug. You can use exercise. You can use red wine. And then there's actually a new drug that just hit the market, which brought HDL levels up as high as 100. And it was the first study. It was just published last year in the New England Journal. And those patients did fine. But, it remains to be seen. That's an unbelievably good level. Time will tell if raising it that high gets you even more benefit. But at least in that first trial, this new drug, which has a totally different mechanism from statins, looks very, very promising. So, yes, ma'am.
Related to that, so I heard that avocados have really high levels of HDL, right? So if you eat avocados every day, can you ever go too high or too low?
Questions about avocados. I have no idea. I don't eat avocados, so I don't know. I haven't heard that before, so I'll have to look it up, and I can email you with the data I find. Great. Yes, sir.
I was raised by HDL in the last year from 40 to 60 per diet.
Oh my! I got 2 examples now. This is great. Maybe the Google guys are a bit different. They're more motivated. So, okay, but one that we can all agree on, I think, is alcohol, right? and this goes under the heading of I knew I was onto something in college, and so now there have been meta-analyses with over 1 million patients, and it turns out that if you're a moderate drinker, which means 1 drink per day for a woman and 1 to 2 for men, you can reduce your risk by about 18%, which is incredible. Now, you don't want to be out on the right-hand side of this curve. You don't want to be 4 or 5 drinks per day, but this is a remarkable benefit, and it probably explains the so-called French paradox, which was first made famous on 60 Minutes some years ago. But it turns out that French citizens eat 4 times the amount of butter that Americans eat. They smoke far more commonly. They take in 108 grams of animal fat per day, which just blows us out of the water. And despite this, they have a much lower rate of cardiovascular death. And the answer is probably because of red wine. And it is red wine, not white wine. It's probably more Cabernet than other varietals. And the answer is probably an agent called resveratrol, which is found in red wine. And many drug companies are now actively trying to develop this. But at least tonight when you go home, you can have your Pinot Noir and know that you're helping yourself out. Yes. Grape juice? I don't know. I haven't heard anything about that, so I don't think so. No? Yeah. Yes. Yeah, so the question is, is there a yin-yang with alcohol? And certainly alcohol raises blood pressure, and so you're always dealing with that versus the pleiotropic effects, all of these unknown effects. I think on the whole, because the French are so unhealthy and they do so much better, I think that you'd have to surmise that maybe it's a net positive. Okay. So the summary for where we are today is that you can control your risk, but only to a point. And this was a paper that was written, it's fairly tongue-in-cheek, and it talks about the polypill, where they will put, several drugs, a very low dose of aspirin, a very low dose of cholesterol medicine, a very low dose of a blood pressure pill together, and they jokingly said they can wipe out 80% of cardiovascular disease if you add together all of these benefits. And we know that we really can't do this in real life, but by taking account of the things we just talked about, you can control a large portion of your risk. And so the question is, how can we find the remaining risk? Where is this hidden risk, and where is the future of cardiovascular medicine? And, at Stanford and elsewhere, we are very interested in understanding the difference between these two types of people. And, I think on the left, everybody knows Churchill, and just an incredible figure in world history. But, for us, you can see that he was always smoking. He drank very heavily and had many hilarious quotes, my favorite of which was that I have taken far more out of alcohol than alcohol has taken out of me. You can see that he's morbidly obese, and he led by, most accounts, a relatively disgusting lifestyle. But he also lived into his 90s. And for the runners in the room, we can look at Jim Fixx. And anybody that recognized this guy, he was a member of Mensa. He wrote this book called The Complete Book of Running, and this actually featured his legs on the cover. You can see what a specimen he was. And he would go on talk shows, and he was really kind of the grandfather of the modern American fitness revolution. And so he would go and tell people that if you exercise, you can live forever, and this will, provide all these salutary benefits. But in fact, you probably know where the story's going. He went out for a run when he was 52 years old, and he fell down and died. And on autopsy, he was found to have between 80 and 95% blockages of all 3 of his main coronary arteries. And so we're very interested now in understanding where this hidden risk is. What are the genetics behind this, where you can be perfect from every known risk factor, yet still have this unbelievably aggressive form of coronary heart disease. And so we're using advances made possible by the Human Genome Project, which was completed in 2000 and 2001, to get at these questions. And so, again, I won't torture you guys. I know you're mostly, engineers, and but remember high school biology. Every cell has 23 chromosomes. The chromosomes are made of DNA. DNA is transcribed into RNA, and RNA is translated into proteins, and therefore you have a human being. And the Human Genome Project has taught us that if you look at all these chromosomes, we have 3.1 billion, with a B, billion nucleotides, base pairs, okay? Now out of that, how many genes do you think there are in man? Anybody want to guess? 3.1 billion base pairs. How many genes? Oh, how'd you know that? It's 24,000. People usually say, I don't know, a million or something like that, but that's incredible, right? So for example, the worm has 30,000 genes, and the rice has, I think 50,000 genes. So we have only 24,000 genes in our entire human genome. So 3 billion base pairs. That's like one base pair for every 2 people in the world, but only 24,000 genes. That's like the number of people in, Pac Bell Park, on a Sunday afternoon. So that's amazing to think that, all this complexity can be derived from that small number. And, even more interesting, the inter-individual difference between us, the genetic difference, is less than 0.01% of those base pairs. So me from you, from somebody else across the world, it's 0.01%. So if I could know the sequence of just 250,000 out of your 3 billion base pairs, I can tell who's who. And that's just a remarkable a factoid, but it's also a discovery that we've been able to leverage to make more insights about cardiovascular disease. And so using technology developed just down the road, Affymetrix is here in Northern California, its competitor Illumina is down in San Diego, we can now simultaneously genotype all 250,000 of these DNA base pairs and then collect huge populations of patients with and without disease and look for differences. Where does one person have an A and another person has a T? Where is a G more common in heart disease and a C is common? And so using this approach, which is known as the Genome-Wide Association Study, GWAS, we really have made quite a lot of headway just in the last few years. And so here's the kind of data you'll see. And so just look at the bottom first. This is what's known as a Manhattan plot because it looks like the skyline of New York City. And the way it's laid out is the chromosomes are along the x-axis, so 1 in red, 2 in blue, 3 in green, and so on. And they'll look between cases and controls, and anytime a variant is more common, we'll call it a mutation for now, so anytime a T is more common than a C, you'll see an increase along the y-axis. And the thing I want you to note is that you're kind of going along from chromosome 1 to 2 to 3, and there's really kind of nothing on the horizon. And you get to chromosome 9, and there's this huge spike, okay? All kinds of action going on here. And we've now studied over 100,000 patients with and without heart disease. This has been shown time and time again. And if I really want to scare you guys, it turns out that up to 20% of the population carries this variant. So every 5th person in the room carries this. And if you have this, it raises your risk of heart attack by 21%, and it raises your risk of early heart attack, like Jim Fix had, by 31%. And so that's really remarkable. And the other killer point here is that this is totally independent of all known risk factors. So whether or not you're diabetic, or whether or not you have high blood pressure, whether or not you're obese, whatever, having this risk correlates with disease. And you can go down and for a few $100, the 23andMe will swab out the DNA from your mouth, and you can know whether or not you carry this risk allele. It's very good, yeah. Yeah, that's a great question. So the question is, if you have this and it's so common, was it an adaptive response that was given to us by Mendel and Darwin along the ways? And I think that you're probably making an astute observation that having sickle cell disease, for example, protects you from having cholera. So that's why sickle cell disease was it cholera or was it malaria? I think it was malaria. So malaria is endemic to Africa. So having sickle cell disease, which puts you at risk for all kinds of complications, protects you in your youth and makes you more reproductively viable. So it's a great question. We don't know why this might have been selected for evolutionarily, but that's very good. Sir?
Suppose I go down the street and I get the test, and I find out that I either A, do, or B, do not have that gene. What do I do with that?
Yeah, thank you for that. I was wishing nobody would ask me that question. Because I also understand that 23andMe is run by Sergey's wife or something along those. Is that right? Okay. So here, you've asked me an impossible question, right? I can't answer this honestly. The question is, what do you do with these results? And I think that we don't know. This gets into more details. We've got very good risk scores, so we can take a person and look at their family history and their blood pressure profile and the size of their waist and do all these things and reclassify your risk. And we use that really to decide if people should be put on drugs like those statins I was talking about, or an aspirin, or whatever. And I think that this really, I'm not sure it's ready for prime time yet, and I think that this is going to evolve rapidly, but we're learning more and more. So I think for now, I'm not sending this for my patients to get this test done, but I think it's interesting, and I might do it for myself just out of curiosity more than anything else. But I wouldn't put myself on a statin at my age, for example. So I don't think we're ready to do that just yet. But I'll tell you where we're heading with this, and we may find new biology which will allow new therapies. So, and so again, just this isn't a statistical fluke. In science we use a p-value of 0.05 to prove significance. That's 1 in 20 chance we found this association by chance. The p-value here has something like 16 zeros, so there's just no doubt this is a very real association.
Does that gene have a name?
It's not. Well, that's the thing. It's not a gene. So this is the most exciting thing, to me at least, is that these variants are occurring in the gene desert, in between those 23,000 genes. And this, when I was going through my schooling, I was taught this is junk DNA. Why is it there? Who knows? But the body doesn't use it. It's just DNA that's there in between the genes that we actually care about. But we know that that just can't be the case anymore. And that's one of the real advances from the Human Genome Project. So 9p21, that's the area on chromosome 9 where these mutations occur, is totally in a gene desert. And so we're trying to find that oasis now. And I promised I wouldn't give you too much hardcore scientific data, but suffice it to say that we are working very hard, thanks to the funding provided by the American Heart Association, and we think we found a new mechanism by which this non-coding DNA is actually controlling the expression of a gene that's very far downstream, 100,000 base pairs away. And we found that knocking out that gene, which had never been implicated in heart disease before, can dramatically alter the expression of cholesterol and atherosclerosis. Here's a knockout mouse who doesn't have the gene on the right and one that has it on the left, and you can see far more of that green cholesterol in its blood vessel, more cholesterol building up around the aortic valve. And these videos didn't play, but you can also see a larger abdominal aortic aneurysm, which is the 5th leading cause of death in humans, which this has also been associated with, by the way, in relation to this gene. So using this technology, which we call agnostic, because we started by saying we have no idea what's going on. We know about hypertension, we know about diabetes, but we're going to say we don't really understand the intricacies of the body. We're going to look across the whole genome, and using this approach, we found this totally new pathway, a new gene, and we hope that this can lead to a new therapy. So very exciting stuff. And it's going to get even better. You guys will know Moore's law, the price of computing going down. You can see the price of sequencing just far outstripping this. The Human Genome Project cost $3 billion and took 13 years. Now if you call Illumina and you agree to sequence 50 people, they'll give it to you for $850 per person, and you can get it done over a weekend. And that's pretty amazing considering that the Human Genome Project was basically a decade ago. And so the hits are just going to keep on coming. And we can all be like Jack. That's the plan. So in conclusion, cardiovascular medicine's come a long way. And I think that it's always fun and interesting to start with the history to really appreciate the fact that we're standing on the shoulders of giants. And many of these incredible advances were due to serendipity and astute observation, but really have laid the groundwork for amazing surgical, technical, and drug discovery advances. But I think the future is going to be based more on this agnostic approach where we're going to liberate ourselves from our preconceived notions and be able to make even more interesting discoveries about the disease itself and not merely risk factor modification. And then for you, if you didn't have the foresight to choose your parents wisely, the advice is pretty simple. Eat right, exercise more, ride your bike to work. Most important, don't blow off your blood pressure. Don't let your physician blow it off. This is something you have to take seriously. Never smoke unless you want to have a cigar with me outside afterwards. And keep your cholesterol in check and explore Napa Valley. And if you can, do your best to support the American Heart Association in their remarkable goal of helping stamp out cardiovascular disease. So thanks. Yes, you, sir.
Question on statins. Is it true that once statins are prescribed, you cannot come off of it?
No, there's no problem doing that. The question was, can you come off of a statin? And yeah, there's no rebound effect, and it's very safe to stop it if you so desire. Yeah, the question's about insurance, and certainly we deal all the time with pre-existing conditions, which is a concern. But I think that the most concerning thing, at least from my perspective, was discrimination based on genetics, because we're now learning all this information. What if you sequence your whole genome looking for this heart disease thing, but you find out that you carry a risk for sudden cardiac death, and the chances are that you're going to die unexpectedly in your 40s? And should the insurance company be able to keep you from getting life insurance, for example? And there's actually an anti-discrimination law passed just a couple of years ago. I think it was GINA, or I forget the acronym. But basically, insurance companies are no longer allowed to make any type of discriminatory behavior based on the information that we're getting from our genetic research. So that's very important. Yes, sir.
So there is a certain band of probability of formation of second disease purely determined by genetics, right? And there is certain by the other side.
Yes.
So what is the ratio of this balance?
Yeah. That's a great question. So how much of your risk is genetic and how much is from the environment? And it's probably 50-50. And so the identifiable risk factors, blood pressure, cholesterol, smoking, it's about half. And then your family history and the kind of unknowns that attack a guy like Jim Fix is probably another half. So that's why we think it's so important to study this from a bare bones genetic approach going back up. Yes, sir, in the back.
It seems to me that some of the problems with the hearts are more like mechanical, right? It's blood, you're starting your heart. And then there's this good relation. It seems like the electrical system is not working well. So the question to hold is, what's the proportion of cardiac death that is due to more mechanical problems versus electrical problems? And do the lifestyle changes affect both changes, or just predominantly?
Yeah, the question is, how much of this is a simple pump and how much is electrical and how does it break down? And to be sure, we're just simple plumbers. Everybody makes fun of cardiologists and they're probably half right. But, we take care of all kinds of disease, whether you're having a heart attack and you have a blockage in your artery, whether your heart muscle's been weakened like my buddy English Joe, or whether you have an electrical arrhythmia problem, and so you have atrial fibrillation. And we didn't even talk about these, but they're all, there's tons of heart disease from multiple causes. I think that these risk factors that we were talking about probably impact your risk of developing a heart attack or a stroke more than your risk of having an arrhythmia, for example. But there's been a clear association with the amount of alcohol you drink and your risk of developing arrhythmias. We call it the holiday heart, where people will drink heavily all weekend and then go back to work and they actually have an arrhythmia on Monday. So that's a very common phenomenon. So it's all interrelated, but they actually are very distinct subspecialties within cardiology. Any other questions? All right. Well, thank you so much for coming, guys. It's really a pleasure, and talk to you soon.